unlock the mandible first, and as soon as the mandible is relieved, then we register the bite. See, it is almost 20 millimeters, very deep bite. Mandible cannot be advanced at all. The deep bite was the 15 millimeter and overlaid was the 18 millimeter. After deboogramming by the upper bite plate, we are able to take a bite from that we block up nice. In case of the open bite, like a patient having a truncus or the vertical cross, to maintain the 5 millimeter of the clearance in the posterior segment, you may need a more vertical correction, more bite into the upper anteriorly instead of taking the 2 millimeter. In case of the class division 2 or a severe deep bite cases, first we need to align the upper teeth by the fixed mechanotherapy. As soon as the rectangular base wire will come, then you can take a bite as a class 2 division 1. In a severe deep bite cases, the interincision clearance should be edge to edge or even a negative for the comfort of the patient. Integrated with the fixed applies. Cases having a crowding in class 2 molar relationship, first we have to decrowd the upper and the lower arch, close the extraction space, and then we have to add the mandible. In a such a cases, the vertical correction in the premolar region is almost 5 mm, and anteriorly there will be more than 2 to 4 mm because the bite and the curve of speed is already aligned. To start with the reverse twin block, the patient should be able to bite to bring the mandible edge to edge relation. If the patient is not able to bite edge to edge, then it should not be attempt for the monofunctional appliance. Edge to edge bite, interincisally clearance should be approximately 2 millimeter to jump the bite. How we bite in the register for the class 3 cases. Let us have some short outline design. This is the standard design by Dr. Clark, having a 2 delta class on the maxillary first molar and the lower premolar, and Bolen class added anteriorly with additional class. Adams class labial bone, base flat, expansion screw, and the bite block. These are the design which include the proper retention, stability, and I have a curve for the anatomical masticatory efficiency. All the class must have a good secure retention as the window appliance is a tooth and tissue bone appliance, and it have a masticatory load as well as the muscles from the retractor, muscles from the mandible may try to move the mandible back. The different type of the class can that be used: delta class, Bolen class, eyelet class, circumferential class, C class, or Adams class. In the severe crowding cases where the IMPA is a fear of procline in the lower incisor, you can do the circumferential count in the lower section. interdental class on the lower anterior. Labial bow deviation. The labial bow should be on the premolar to premolar. Labial bow prevent the flaring of the upper incisor and may help to retraction in the retention phase also. The fitted labial bow can be given in a crowding cases where it gives the better retention to the appliance. Designing the appliance without Adams class. Adams class in the some patient in a delicate buccal mucosa may irritate. In such a case, the eyelet class given all the teeth can be used. Bolen class or eyelet class can be also given in the cases with the T and the 2 to integrate the fixed appliance in the mechanotherapy. I have also given the look at how the appliance interdigitated lingual. It gives the intercuspation on the palatal aspect as well as the buccal aspect, so the proprioceptive mechanism will be starting the dead. Only eyelid supported twin block appliance. There is a no Adams, no labial bow, only the interdental eyelid class is given. So there won't be any soft tissue irritation of the buccal mucosa or a labial mucosa. And this appliance or this class can be utilized for the twin block appliance integrated in the fixed appliance. These are my modification for anatomical bite block, which is better for the mastication and the proprioception. The lower block is prevent the eruption of the upper incisor and also help in cutting the incisor edge. This is the lower bite block, which is occluding the upper incisor. So the supra-eruption of the upper incisor is also controlled, and the cutting of the foot is also facilitated by creating the lower block. Modification that I can in the standard between block are making the anatomical bite block, extending the lower appliance till the last erupted molar. Eyelet class is given distal to the first molar. The eyelet class between the second molar and premolar and the first molar can be added. These class can be cut as and when you require the eruption of the posterior segment. Extending the lower appliance till the erupted last molar is to enhance the anchor and to minimize the flaring of the lower incisor. In this case, severely increase the overjet where to achieve the edge-to-edge relationship is not possible. So lower blind total is extended anatomically anteriorly till it can contact the upper incisor. This extension will prevent the supra-eruption of the upper incisor and control the lip trap also. In addition, if you want to retract the anterior teeth, the extension will be a platform of the incisor to prevent the incisor dumping. See how the cantilever type of the bite block is extended to hold the upper anterior teeth. The stages of the treatment: active phase, supportive phase, and retention phase. I will be very shortly enumerate how the active phase is going on. The active phase starts with the appliance delivery. It includes the sequential posterior occlusal trimming and end with the horizontal correction to edging. Once the patient has started the wearing the appliance 24 hours a day, the expansion of the jab screw will be activated. Once the trimming is also carried out after the patient is comfortable wearing to the appliance. Trimming should be done to carry out 4 to 6 week interval. The trimming is done distal to the lower second premolar on the upper bite block. The most important part is to avoid the trimming of the leading edge, so to avoid the mutilation of the appliance. 1 to 1.5 trimming is done Sequentially, this sequential trimming is done to avoid the lateral tongue thrust which would impact the molar eruption. Every 4 to 6 weeks, 1 to 1.5 trimming is done. See how the trimming is carried out. Finally, only the leading edge is remaining. So there is no eruption of the posterior teeth. Totally trimming is done. Distal occlusion should be corrected by end of the active phase. Ideal overjet and overweight should be achieved. The active phase will last almost 6 to 9 months. Distal occlusion should be corrected at the end of the active phase. The ideal overjet and overweight should be maintained and the active phase. This is the modified retention plate after the active phase of the twin block therapy is completed. Once the clasp on the incisor will be prevent the supraeruption. An inclined plane is given such that the lower incisor are included and the posterior teeth are free to erupt to close the posterior open bite. See, this is the supportive phase. Only the uplines have a adduct on the premolar and posterior teeth are free to erupt. Aim of the supporting phase is to maintain the correct incisor relationship until the buccal segment occlusal is fully interdigitation. Support phase will last 3 to 6 months. Timing of the treatment. In this study, the author compared only the treatment group of the late stage group. Early treatment group was CVMI phase 1 to 2 and the late group include the CVMI stage 3 to 4, 3 to 5. This is the pre-pubertal and the pubertal growth. The finding of this study is supplementary elongation of the mandible in the late treatment group was more than twice in the early treated group. In another systemic review, the author concluded that the amount of the supplementary mandibular growth is significantly larger if the functional treatment is performed around the pubertal growth spurts. Also, one of the systemic review on the treatment timing conducted, the functional jaw orthopedic may be more efficient if the treatment during the pubertal growth phase is coincident. All the literature, including the class 2 functional therapy, should be done around the pubertal growth spurts. And in the class 3 functional therapy should be done CVMI stage 1 or 2. It is in a pre-pubertal phase. Early treatment case. We will look at the case which is started. We have early CVMI stage 1. We started this case is early because he had already fractured one central incisor due to the trauma. The other reason was to avoid the psychological trauma because of the protruding the teeth. Weber is a 12 years old boy presented at our clinic with his chief complaint of the protruding of our front